And like, I'm so excited about this topic today because we've seen such a shift towards, interventional glaucoma. And I mean, that in itself is such a journey, as we'll talk about. And there's just like so many ways that, we can be creative in utilizing what we have in our toolkit for the best outcome. And that's what I love right now, is that we're really being able to like get back to patient care and looking at quality of life. And so, without further ado, let's get started. I'm so glad you guys are here. Thanks for joining us. I'm Deborah Ristvedt. I'm from Alexandria, Minnesota. I'm with Vance Thompson Vision, and I focus on cataract, glaucoma, and oculoplastics. And so it's just been a wonderful journey throughout my career to really see how minimally invasive glaucoma surgery has transformed how we're treating glaucoma. And we're really getting back to, being great doctors by being able to intervene earlier and in a safer, effective manner. And so I'm going to introduce my colleagues, who are some of the best people in the world. This guy was an intern when I was a senior resident. So Doug McGraw, tell me a little bit about yourself.
Yeah, so Deb was my senior resident at Michigan State. So learned a lot from this lady. I'm in Chico, California now. Very comprehensive ophthalmology practice. Pretty high volume. We do a little bit of everything. Just couldn't be more excited about this particular topic. Is kind of our sweet spot. You hear the word prevention a lot, and I think that's kind of the gold standard in medicine. We want to prevent disease. We don't want to treat disease after it's already happened, and that's, I think, the way that the field is heading.
Yeah, awesome. And Arkadiy, you and I, love to talk about glaucoma all day long.
Yeah, we could.
And we've been on this journey together.
Right.
We've sat here talking exactly about what we're talking about today, but we've watched the innovation through Sight Sciences, and that's what's like so cool. So tell us a little bit about where you practice as a glaucoma specialist.
So my name is Arkadiy Yadgarov. I'm a glaucoma specialist in Atlanta, Georgia, practicing about 8 years at a practice called OMNI Eye. No affiliation with the OMNI device, but it's destined to be together. Essentially, the journey has been alongside Sight Sciences, kind of side by side. Back 2017, that's when the OMNI was really starting to come out into the market, and I've just seen a really beautiful amount of innovation every few years from Sight, and now here we are now on the next step of innovation with OMNI Edge, so we're very excited to talk to you about it.
We have to start here when we talk about the journey that we've been on when it comes to treating glaucoma. And, nothing happens overnight. And so I just really want to call out the fact that Sight Sciences and the development of a truly novel device has been in the works for 15 years. And so when you think about, when the company was founded to when OMNI first became available to us, which I remember really, really well, in 2018, I was so excited to have something in this space that was going to be able to take care of patients that, would usually go on to a trab or tube, to tell you the truth. And so, nothing comes without going through that journey. And I'm sure you guys in the audience have been on that journey as well, as you explore different ways to treat glaucoma in the angle. And, Arkadiy, we talk a lot about this where, and Doug, you mentioned where we want to be proactive now. That's what interventional glaucoma is all about. It's more than a mindset now. We're actually really, truly getting to the point where we want to be interventionalists and we want to treat early.
Right.
I mean, how devastating is this to you, Arkadiy, when you think about glaucoma?
As a glaucoma specialist, and really as anybody who manages glaucoma, the longer you watch your patients, the more you realize that glaucoma is a disease that fights back. It's chronic. It can surprise you. Years of stability, and all of a sudden things can get worse. And so one thing we realized is that the status quo of just medicine don't seem to be the final solution for stability of glaucoma. And that's really why the boon of interventional glaucoma has occurred, is because we're trying to figure out what do we do here to prevent what's been happening, which is progression to over there, right? And so as a glaucoma specialist, I don't want referrals on the right side. What I'd like to know is how can we keep patients as long as possible on the left side of the slide.
And Doug, you practice as a comprehensive ophthalmologist. And so what was kind of your journey like when you thought about glaucoma and treating it in a different way?
Yeah, sure. As somebody who doesn't have, Arkadiy's excellent glaucoma fellowship background, I'm somebody who, I do a lot of tube shunts. I don't like doing tube shunts as much as Arkadiy does. So I was, really thrilled when we got some interventions that, are somewhere, between just putting people on eye drops or SLT laser and then going to more aggressive filtering surgery. This is something that's just been tremendous as far as intervening earlier and not having to have as many patients get to that, that end stage where we're, doing more aggressive surgeries.
And guys, this happens in our practice. When we only had drops, laser, and then tubes and trabs, we were practicing as a reactive kind of group where we would wait for progression instead of, responding early. And so, this is really kind of what, came home to me when I started to think about how I was treating glaucoma. Do we really need to be putting patients on drops, as first-line therapy, or are there other options? And that's where we've found that early intervention is actually restoring the natural outflow pathway, where a lot of patients don't have to go on to filtering surgery. And that's why we become so passionate about it. But it was really taking a step back to say, let's really be honest with ourselves when it comes to what we're making our patients do. I mean, I can't take a vitamin. And I floss my teeth before the dentist, but I'm not consistent with it. And so we were able to ask our patients, how are you really doing with your drops? And that's where, the why started to come in. Why are we changing our paradigm and our mindset when it comes to treating glaucoma?
Right.
It's because we're looking at quality of life. We're looking at, our patients that are really struggling with their eye drops for various reasons. And now we have the ability to offer new solutions. And Arkadiy, was that the aha moment for you? I mean, you've had these patients in your office.
Yeah, essentially, if you look at a glaucoma specialist practice of the past, it was patients that looked like this. It was patients that were progressing, and we used to think, well, you're not progressing quick enough. Because we were so scared of doing major incisional surgery and all the complications that happen with that. And so the aha moment really came in 2018 when OMNI was born, and even a little bit before that with Trab 360 and Visco, which was, oh my goodness, here's this minimally invasive procedure that not only was it to some degree easier to do than a trabeculectomy, but to a major degree was easier on the patient and easier for a discussion with the patient of let's do something now, before seeing the amount of really cosmetic and redness and dryness and progression of glaucoma. So it's been a godsend having this MIGS option now.
As a third-generation ophthalmologist, I came into multiple medications prior trabs because that was the only option. And, they're in your office. These patients are in your office. And, I think sometimes there's that, do I have enough time to have the discussion of, interventional glaucoma, or do I feel confident in myself to take on this, big space now? And Doug, how did you allow yourself to say, I'm going to go to the angle as a comprehensive ophthalmologist because it's the right thing to do?
Yeah, I mean, I think that's the great part about, angle-based approaches. I think really any seasoned ophthalmologist is, a very accessible space. And the great thing about OMNI is I think it's very approachable to somebody who is new to the angle. You're not, putting a giant implant in that, you're halfway in, the patient jerks, and suddenly you have a massive cyclodialysis cleft. It's, the catheter is quite flexible, so it's very forgiving as far as kind of a learning instrument. And I think once you kind of feel empowered to start doing those cases, then anybody who has good enough hands to do cataract surgery, I think, really needs to be offering MIGS in their practice.
Yeah, and I think where it started with me was starting in conjunction with cataract surgery. Really, utilizing that time, I had already made an incision to get really good at working in the angle and getting good visualization. But it all came from the belief system of, are we doing the best for our patients? Are our drops really that safe? And it's so interesting when you look at market scope analysis, 80% of preferred practice patterns is still to start a drop. And so I feel like this is a time, you guys, where we really need to, get going on offering SLT as first line, as thinking about drug delivery, as thinking about early minimally invasive glaucoma surgery like OMNI to really revitalize that outflow pathway.
Yeah.
And Arkadiy, we've talked about this slide because it is like such a robust slide when you start to really think about like what we're asking our patients to do when it comes to drop therapy.
Yeah, I think one thing I was going to say is, some doctors go, well, I don't know, where do I position OMNI or how do I get started? And just like you said, it starts with a mindset. So first line SLT should be part of your mindset, right? And then some patients just need drops, and that's okay. But then if they need a second, that's when you need to start thinking, okay, one drop isn't helping. What else can I do that avoids the need for a second or a third medicine? Because as you can see here, it starts getting burdensome. Making a patient use 2 to 3 bottles a day every single day for the rest of their life, the quality of life starts to decrease. And that's where I think a lot of the doctors here that are listening going, where can I start? Well, you have any patient on 1 bottle of medicine and now is needing maybe a second or a third, that's where you start. That's where you start talking to the patient about, how about we talk to you about alternatives like a standalone OMNI procedure, which may help improve the natural drain of the eye. And remember that every single one of those drops on that, that we use, they don't really help the drain like the surgical options we have, right? So I think it's a very intuitive approach.
That's amazing. And so, we've kind of prepped this. We've teed you guys up, to talk about what we're truly passionate about. And we're going to get into kind of pro tips today and some of the differences with the OMNI Edge coming out as it's evolved and as Sight Sciences has taken that time for innovation to go to the next level. And so we kind of led with quality of life. When you think about, the cost when it comes to patients not being able to drive because of visual field loss,
right.
Those who are getting older and they're having a really tough time, just with stability, fall rates increase and all these things. And so you diminish that vision and you decrease the quality of life. Do you guys feel like you're putting quality of life into your decision making?
Absolutely for me. What about you, Doug?
Absolutely, and just checking somebody's vision on an eye chart is it's such a rudimentary, thing to look at. When you start talking to patients and actually hearing their stories, this is what they talk about. This is what they care about. Their ability to continue their activities of daily living, have their freedom, and you start challenging people's ability to drive, and that is really a life-changing kind of consequence.
Exactly. And just to what you said, it's not just about the eye chart, right? We're throwing up, how we check contrast sensitivity. We talk about contrast sensitivity all day long as cataract surgeons and as, surgeons that are addressing glaucoma at the same time. Which IOL do I pick for my patient that maybe has visual field loss? What is the best candidate for X, Y, and Z? And so when we look at contrast, it really is amazing how it doesn't take much of a change from glaucoma to affect contrast.
Right. So, one thing I think a lot of us doctors are guilty of is we look at the fields and we look at the nerve findings and we think, well, are they getting worse? But the truth of the matter is that we don't check contrast sensitivity unless you're in a research or academic center. But what's happening in that kind of smoldering activity of disease is before even you see field loss, the contrast sensitivity is starting to get damaged. That's what happens in early glaucoma. And that's what we have to understand is that if the pressure's 20 or 21, not optimal, but the fields aren't getting worse, that shouldn't be a sense of that false sense of security. It should be you going, okay, well, pressure's not good enough. It's possible now their contrast sensitivity may be dropping. What can I do to lower the pressure? Because we know that pressure is the number one determinant of progressive glaucoma later, and not be reactive and waiting for field loss. So I would say contrast sensitivity is huge for patients because it's your nighttime vision. Mm-hmm. So patients that tell you, well, I don't drive at night anymore because of, I can't see well, that's somebody that's lost contrast sensitivity. And we need to do a better job about being more aggressive with glaucoma treatment than we've been doing because of all the damage to contrast that we're having even before field loss.
This is another point that is so powerful when we talk about, the why. Why are we intervening earlier? If you look at what happens with intervening sooner rather than later, what happens?
Yeah, I mean, if you look at a patient that has late stage glaucoma, they have an OCT or NFL like in the 50s, they have like substantial field loss. The patient wasn't born like that. Something happened in their lifetime where they lost that nerve tissue, and our job as physicians is to identify people kind of earlier in this graph, intervene, so that we're not getting into those kind of visually consequential impacts of glaucoma.
And I think that question was, do we have enough data? We've been asking that for years and years, and the answer is yes. We have plenty of data to support the fact that earlier intervention reoptimizes the outflow pathway to prevent incisional surgery over time. The light trial was huge in that. Right. We could talk about the light trial with SLT until we're blue in the face, but that really, kind of was one of the major studies to show that early intervention and going to the angle was proven to be successful. And same with, MIGS technology like OMNI, revitalizing the system. What happens with resistance? It's not just the trabecular meshwork. We have 3 points of resistance that we're trying to address and doing it sooner rather than later.
Right. And commonly I get some doctors telling me, well, it'll only work for a few years, and what are we going to do? And to kind of counter that, even if whatever MIGS you choose, like an OMNI, lasts for 3-4 years, right, and may not last 20 years, but look what you can do to that rate of progression. You could substantially modulate their disease so that you may not need a major interventional surgery in their lifetime, right? Even if they progress some. And that's the goal. The goal is to improve their quality of life in their lifetime. You're not trying to, get their pressures down and reduce glaucoma until they're age 150. You're simply trying to do it in their lifetime. And so a MIGS may get that job done without having to go to a trab or a tube.
And so, Arkadiy, talk to us a little bit about the differences with OMNI Edge versus Ergo.
Yeah, essentially, it's going to feel very familiar, but what you're going to see is a little bit more distension in the canal. OMNI Edge has more viscoelastic delivery. And remember that it's continuous, It's got that TrueSync technology, and so you're getting a continuous dilation of viscoelastic in the canal and a little bit more than ergo. And I like seeing a little bit of that distension in the canal. And so to me, this is just a very nice next step in terms of the evolution of viscodilation of the canal.
So the nice thing about it, you know, I've seen the evolution of OMNI and the way that they've listened to us docs to say, hey, this could be better.
Right.
And so the device itself has, you know, become a lot more elegant over time. When you actually go into the angle, you're not scoring tissue, getting that bleeding that we used to get. And so they've made it really intuitive, in my opinion, and they've continued to allow us to have control. And that's what I love, is that when I'm turning the wheel and dispensing viscoelastic, I can feel the amount, the rate, and the timing of everything instead of not understanding where you're at in the angle. Do you guys agree with that?
Absolutely. I mean, you know, not having to have an assistant to, you know, elude the viscoelastic, you know, the viscoelastic not just coming in an uncontrollable bolus, you know, it's a smooth, consistent feel. The feel of the new wheel is really great. And I feel like, you know, it's your hand balancing that causes the tip of the device to move when you're inside the eye. So it just gives you that really nice smooth feel. I think the tip of the new Edge device is really fantastic. With the older device, one of my tips that I tell people, you know, get it up, you know, all the way against the wall, and just kind of wiggle it, you know, till you see a little cleft create. The new device basically just cannulates. As soon as you put it in, it just cannulates so smoothly, you almost don't even feel like you need to kind of move the device around at all.
Yeah, and like we talked about, visualization is the key. And then understanding how you're treating glaucoma, and I love that we have versatility. I really do. Because, you know, I've really started to rethink how I'm treating glaucoma when it comes to glaucoma suspects, to ocular hypertension, to mild, moderate, to severe, to secondary, right? We have all of these options at our disposal now to really be able to customize and individualize care. And so one thing to highlight about the OMNI and why we're doing what we're doing is exactly what we talked about with the 3 points of resistance. Arkadiy, we know, Doug, we know that, you know, most of the resistance lies in the trabecular meshwork, but you guys have been in the angle enough to know when you see that collapse in Schlemm's canal, bypassing is maybe not going to be the right move for that individual patient. How do you guys strategize that, or how do you look at patients to, you know, kind of decide what you're going to do in the angle?
Yeah, I mean, I think in terms, I mean, there's a lot of MIGS on the market, right? It can get overwhelming. Like, whoa, you got this and you have that. I think when you start really looking at the MIGS and you think about the OMNI, what OMNI allows you to do as a surgeon is really tailor it to how you feel is best for the patient, whether it's a certain amount of clock hours, whether a certain amount of dilation and trabeculotomy, and kind of you as a surgeon deciding what's best for your patient goes a long way, and being able to treat 306 degrees and whatnot. So I think the OMNI, in terms of versatility, to me is takes first place.
Yeah, and just the fact that you can't look at a patient and know exactly where the point of resistance is.
No.
And it just gives us the ability to treat all three just empirically. You know you're going to be treating the meshwork, you'll be treating the canal, you're going to be treating the collector channels on every single patient. And I like to have the discussion with the patient that hey, we have different options available. I really like this option. I think it allows us to basically optimize the patient's own anatomy.
Mm-hmm.
And
so in terms of discussion, that's important because patients like to hear that you're going to help open their drain. They like to hear that you're going to clear it out or dilate it. They like to hear that more than stenting, I find.
Mm-hmm,
They find that they're more intuitive of an approach when you talk about an OMNI procedure than you would with the stenting. So I think between the versatility of the clock hours, the dilation and the trabeculotomy that you get, I think it's quite a fantastic device from that standpoint.
And so that's what's so fun about this device is we can use it in conjunction with cataract surgery, or we can use it in a pseudophakic who maybe has had a prior MIGS procedure. We still have options. And that's what we want as surgeons. We want optionality to be able to individualize that care. And so, that's exactly where we're going. We're not only thinking about, as cataract surgeons, what we're doing at that moment in time in the angle. We're looking at this as a journey, and that's truly what it's been. That's what interventional glaucoma is all about. It's about the journey and setting that patient up for future success. And that's what I love too, is, if you've missed that opportunity in cataract surgery to go back to the angle, you still have that option and have the confidence to think about your standalone cases when it comes to utilizing the OMNI device. Do you guys feel like in a pseudophakic patient, it was more difficult initially to get on board than with combination cataracts?
That rings true for most surgeons. It's a lot easier when you're already doing a cataract to kind of tag along the MIGS. Part of the new mindset of a standalone proactive approach is learning how to talk to the patient and saying, look, let's take you to the operating room to treat your glaucoma. It's not about the cataract anymore. That is a mindset shift. That is a habit that you need to build, but there's got to be a strong why. And when you take into account the patient, the quality of life, the evidence, that's really what's going to make you feel confident about offering MIGS standalone.
Yeah, and I think the other edge of that sword is, our patients, by and large, have a great experience with cataract surgery. So they're already familiar with that, and they say, oh, cataract surgery is a breeze. So in many patients, in the right patient, I think it oftentimes eases the discussion. Hey, it's going to be a very similar experience as you had with your cataract surgery. From your standpoint, very, very much the same. And, post-operatively, because you're not phacoing, you're not going to get that corneal edema. Usually the vision's actually quite clear post-op, day one.
And our patients are sitting right in front of us. And it's kind of the analogy of, buying a red truck. If you buy a red truck, you're going to see red trucks all over the place. Well, if you're looking for those patients that would be good candidates, you're going to find them. And so that's where I have the team involved. I have my team asking patients how they're doing with their eye drops. We're looking towards, basically, getting that opinion of how often are you missing your drops? And so we've totally changed the verbiage now in our practice when it comes to really being honest and truthful about how this is going for the patient.
Right. Make it patient-centered. Absolutely.
All right, Arkadiy.
Okay.
So let's look at some patients that are right in front of you in your clinic setting.
Yeah, so let's look at this case right here. It's a 71-year-old patient he's phakic. He's got early cataracts that are starting to impact his vision, and something that will, of course, be very familiar to the doctors here. And interestingly, there's definitely a visually significant cataract, but the patient was kind of ambivalent about the surgery, wasn't quite sure whether they wanted it or not. And on the previous visit, as a lot of us doctors can get busy, we come in, the glaucoma seems okay, and there's no discussion of MIGS, right? And so really what I'm getting at is, just like Deb talked about, is get to know your patient, or even at least have the technician start asking the right questions. And so when the patient came in for a typical glaucoma checkup, I looked at their history of present illness, and they said they only use their drops 60 to 70% of the time. And that to me is a red flag. Even if you have stable testing, as soon as your compliance starts to drop, your risk of progression in the future goes up. So you see here the testing, there's legit disease, this is real glaucoma. I don't want this to get worse, right? I don't want to be reactive here. The patient's not a great medication candidate. There's ganglion cell damage, there's inferior arcuate on the visual field. And my job is to figure out what is best for that patient. Anything less than 100% compliance, to me, is at risk of disease progression. That's shown in many studies. You really need up to almost 99 to 100% compliance. So let's delve further, right? Talk to your patient. It's not just about in and out, it's how really are you doing? Why are you forgetting? And as you get to know your patient and realize drops are a burden, that's when you as the doctor can become their friend, their helper, their partner in their disease journey. So essentially, I knew that this was a patient that needed MIGS, right? And had he been standalone or pseudophakic, I would have done pseudophakic, but he happened to be phakic. Now here's what's crazy, right? He was ambivalent about cataract surgery despite having cataracts. And as soon as I gave him the option of MIGS, discussed the benefits of canaloplasty with trabeculotomy that may reduce his need for medications, he was on board. And he's like, yeah, take the cataract out while you're there. Now look at that. I wanted to do cataract surgery. He wasn't sure. I offered, well, let's take care of the glaucoma, maybe get rid of your medicines, and that's somebody that went, well, let's do it. And so what I find is something that happens is patients who are not fully compliant, they're miserable. They don't want to be using that drop. And they almost self-select to be your MIGS candidates. So you see anybody with poor compliance, they're going to be much more on board with MIGS than somebody who's 100% compliant. Do you guys find that
Absolutely.
to be true?
Yeah, absolutely.
Yeah.
And they're excited.
Right.
They're
They
so
are. They are. They're like,
excited.
let's do it. I mean, and you're like, wow, like this is amazing. So that's the surgical plan: cataract surgery with canaloplasty trabeculotomy using the OMNI device, and essentially here's a surgical video. This is with the OMNI Edge. So there's going to be more viscoelastic delivery. It's going to be a little different of a view. This is a direct gonioprism that I'm using, so instead of turning the head. But as you can see here, like he talked about, the tip of the cannula is amazing. I mean, it just penetrates the canal so smoothly. And you're seeing that blue catheter go around, and now as I'm retracting it, the canal starts to stretch and dilate even more than with the ergo, and that's really nice to see. And once I'm done with the canaloplasty, I'm now ready for my trabeculotomy, and I incise and unroof that trabecular meshwork. So a very, very suave, very smooth type of procedure. Now in his mild eye, I did, one quadrant to one hemisphere, but in the more moderate eye, I decided I'm going to tailor it to the needs of the disease and essentially performed more treatment. And that's, again, the beauty of the procedure.
So there's one case, cataract in conjunction with OMNI Edge. Now this is a pseudophakic patient in her 70s, and I'm just gonna go right to the money slide here. On 3 medications, but her visual fields and her OCT actually look pretty good. So she's been compliant over the course of, years. My dad started seeing her, and he did her cataract surgery. And so, this is another thing that you guys can be thinking about when it comes to who's in your practice. And so with a history of ALT, still on 3 medications, this is a money slide. I wouldn't want eyes like this. Look at the periorbital atrophy, the erythema, and she has, fluorescein in her eyes, and you can just see the staining without green light, or blue light. So, this is a case of a patient who actually is really trying to manage their glaucoma by taking drops. We have so many options for glaucoma now. I really think that we need to consider minimally invasive glaucoma surgery. And she was so excited for that opportunity and that option. And I think sometimes we're our worst critics or enemies when it comes to, well, patients won't want that. They'll be scared to go to the operating room. But have confidence in what you're doing because we have the data. And so through an OMNI 360 180, we were able to get her off of all medications with pressures in the teens. And look at her post-operative results. It makes me want to cry because these are the patients that you fight for as doctors, and this is what it's all about. So you guys have heard it, right? You've heard from us today that interventional glaucoma is here to stay. You've heard that innovation takes years in the making, but it's here, and they continue to listen to us to make things better. We've increased the volume of viscoelastic that we're able to use in the angle with OMNI Edge, and that's the main difference from OMNI Ergo. And so really to highlight the fact that this can transcend across multiple areas of our glaucoma patients, from the phakic in conjunction with cataract surgery to the pseudophakic patient. And so it's just such a great tool in your toolkit and your tool belt to be able to have for great patient care. And so you guys, this has been so much fun. I could nerd out to glaucoma all day long. And you guys have been really instrumental in pushing that needle forward. So thank you.
Thank you.
Yeah.